I wanted to start by having just a few words about military sexual trauma, because we know that this is an area that has been a unique problem that is being targeted for treatment by VA. I was going to ask Dr. B. Mabry to say a few words about that as we then go into our further questions. Vivian.
Sure. And so thanks for bringing that up. Military sexual trauma is a target area that VA addresses. VA addresses this free of charge, regardless of the status of the veteran, regardless of being male or female. And so one of the things that we need to point out is that military sexual trauma, it has occurred in about 15% of veterans, looking at Kimmerling data and also looking at OIF data that Dr. Haskell and colleagues have done. Dr. Washington has additional data about its importance for homelessness among women veterans. And so this adds a layer of complexity, like Dr. Evelyn Chang was talking about, and should be included when we're thinking about complex veteran care and social needs and subsequent potentially PTSD and other mental health issues. While military sexual trauma is an event, it's highly associated with developing PTSD and also with having unmet needs and other risk factors for our veteran community.
Thank you so much, Dr. B. Mabry. I wanted to be certain that we at least gave a little bit of recognition of how there are some unique issues that have long-term consequences for the segment of our veteran population that is involved with this. I also wanted to emphasize the fact that we've got a number of issues that are current issues that are impacting access to care for special populations and general populations in VA relative to our current co-occurring pandemics of COVID-19 and what that has done. And I know Dr. Chang referenced that some in her talk, and how that has impacted access for our populations, as well as the pandemic of racial social injustice and Black Lives Matter and the demands for more understanding and addressing issues related to our racial and ethnic minority groups. I wanted to open that up to our panelists to see if you had particular recommendations about how we should address these issues as they relate to access among veterans.
I'll just make one quick comment. When we talk about these issues, we have to talk about trauma. Trauma in the form of discrimination, in the form of racism, in the form of social stressors, and layers of trauma that are consistently occurring in people's lives, especially our vulnerable veterans. And so many of the approaches and strategies that have been presented, one of the key features that would have to be incorporated would be understanding the trauma that has occurred due to the social context that the veteran lives in.
So very true. Thank you so much. Because when we as service providers do not represent the groups that have experienced those traumas, it may be not a normal thing that we consider as we are interviewing those populations and considering their needs. Other things that we should be thinking about implementing, it's like, what happens Monday morning when we go in to deliver services? What are the things we should be doing differently as we think about the discussions of the needs of these special populations?
So just to jump in back to your, to your question about what we should do Monday morning, but also to thinking about the points you made about the pandemic and Black Lives Matter. So prior to the pandemic, perhaps when we thought about access, we thought about from a cultural perspective, perhaps the cultural and social influences on how people think about health and illness and how that affects access. What I think the Black Lives Matter efforts and activities have uncovered are some of the structural inequalities in systems of care and other institutions. And so that should challenge us when we think about access for special populations, is to think about the reverse, that systems of care and institutions, whether it be the VA healthcare system or others, have cultures of their own and have activities and practices, some of which they may be aware of and some not, that influence sort of that fit and that acceptability of healthcare services for veterans. So in thinking specifically about equity populations, I think it would be important for us to examine where these structural inequalities might be within the VA healthcare system or within healthcare practice. One example are systemic biases in some of the algorithms, for example, used to determine which patients are high risk, high need, or other sorts of scores that might direct access to high resource services. One approach moving forward as VA rolls out major policies, it might be to look at them through an equity lens. So to adopt equity in all policies and think about perhaps unintended consequences and how that might be one step toward recognizing and perhaps undoing some of the structural inequalities. One thing I should also add is that the VA has an Office of Health Equity. The VA Office of Health Equity earlier this year, prior to the pandemic, revised the Health Equity Action Plan, which is a guiding document that lays out a 5-pronged plan for the VA to proactively address equity-related issues. That information is available on their website, which is referenced on my slide about special populations.
Thank you, Dr. Washington. I must say that as a member of the National Academic Affiliations Council for VA, we are also looking at issues that should be impacting potential training of those who are part of the VA workforce to better address these types of health equity issues. And I would pivot to you, Laura, to maybe comment on other workforce issues that, especially from you as your role as National Director of Social Work, that might be able to address some of these health equity issues as well.
Thank you, Dr. Southpaw. And I think Dr. Washington also spoke about this in her remarks earlier. It's about, the workforce, the diversity of our workforce. So as the Black Lives Matter sort of began really taking a lot of activity, the National Social Work Office just so happened to be in our Leadership Council meeting, and we decided as a group of leaders, social work leaders, that we needed to have an action plan, and that where we needed to start was with our own workforce, the social work workforce in VA. And so I'm pretty action oriented. So I really appreciated the comment about what do we do on Monday. So I've already emailed out to far and wide to the social work workforce in VA a reminder that in our code of ethics, it specifically talks about our responsibility for social workers to act to prevent and eliminate any domination of, exploitation of, or discrimination against any person, group, or class on the basis of the protected categories. So we've created an action plan that has 3 levels, both the individual level at the local facility level, each social worker, as well as at the regional level or VISN level, and what I expect the social work leaders in those spaces to do. a lot of detail in the action plan, as well as then the national, what we're going to do on a national level to try to address this. And I've heard back from colleagues and peers from other professions asking if they could share it, asking if they could build something equivalent in their sphere of influence. But I would really like to see VA take this on and specifically have really concrete actions that we're going to do to address these issues.
Thank you so much, Laura. I think another special population in VA that we all know about and that is uniquely addressed and well addressed in VA are spinal cord injury populations and our amputees. And I wonder whether any of our panelists would like to comment some on specific programs or stressors or unique needs of those populations, especially again with the current crises that we're in. Levelyn, you're muted.
Oh, thanks. I'm not completely familiar with the spinal cord injury program and the amputee program. However, I do know that that the spinal cord injury actually has its own special primary care team. So it's not in every single urban primary care or urban medical center. However, there are specialized primary care teams where they have an interdisciplinary primary care team that focuses on the needs, so they can actually develop individualized and tailored plans for patients with spinal cord injuries. In terms of amputees, I know that they also have very robust prosthetics and physical medicine and rehabilitation clinics, and I actually have one of those patients. He's a bilateral amputee, and he actually receives excellent care within our own VA. And I think that these patients tend to stay within the VA because of the excellent care that they receive. I'm not sure how it's been impacted by COVID-19. I believe that if they're able to, they were probably doing a lot of virtual care at some point and probably delaying some of the in-person care, but I know that some of the medical centers are beginning to open up their in-person care if they needed, for instance, a fitting.
Thank you. We are getting a number of excellent questions from the audience, and I'd like to just throw some of those out right now. One has to do with there's a lot of interest, and there's been a lot of discussion with the telemedicine yesterday afternoon, or of new ways of communicating with our patients. And some has to do with providing better access by phone by patients to their providers. And I wondered whether, and of course that is unique to those of us who have worked with special populations, because we know how important that personal touch, that personal communication addresses patient-centeredness. But there's one question about, shouldn't better access by phone or person-to-person communication be available to all veterans who are seeking care? Comments? And these are going to be very quick respondents, maybe one person responding to these, because I have several of these questions.
I would absolutely agree with it.
Dr. Washington?
Oh, sorry. I could make it a very quick comment and answer, and the answer is yes, absolutely. Immediate or not immediate, but timely telephone contact should be available to all. I think what's interesting and what varies is what people consider timely, both from the perspective of patients in different groups, as well as from the perspective of the system. And so really sort of understanding perspectives of different groups, and in terms and at the same time expanding the options for who they might talk to is important to address that.
Great. There was another question that came through about how we could better meet the needs of the families of veterans within our facilities. Any comments about that? I know that VA has pivoted during this time of pandemic and expanded its access in certain situations under stress, but any other comment, any other feedback regarding how we could better meet the needs of families, especially when we're talking about delivering primary care, which we know families are an important part of health and healthcare. I think what we'll do is we will move on to some additional questions that have to do with, and we'll think about that and maybe come back and we'll add that in since we have about 8 minutes left during our discussion.
Paul?
Yes, please.
One quick response is, and this is just extrapolating from being a primary care provider, is to make sure that we are checking in with the patient on who their support system is so that we understand that as providers. I think many of us do that. It may not be part of the systematic routine, except for our social work colleagues do it, I think, much more intentionally. So making sure that we do that so that our veterans with complex needs and with lots of vulnerabilities have told us who they go to when there's no one else.
Right. Yeah, and this is Laura. I would just add in there and to kind of just further expand on some of my comments that, you know, when you meet with a veteran from the social work perspective, you really assess for who their social supports are. And so typically that's family, that's friends, that's a neighbor, that's someone at the store who they see each time they're there. Like, who are those people that matter to them within that sphere of sort of family? And so we would definitely be assessing for that and making sure that we build upon that if the people that are meaningful in their life. And when there's no one, that also helps us to create a treatment plan for them to really work on developing a social support system and identifying people who might be able to serve in that role within their.
Great. Thank you. Thank you. There's another question about how do we better create a welcoming environment for those who have particular stressors, both a cultural and physical environment, and specifically when it refers to women veterans who may have been experiencing military sexual trauma. And we know that VA has taken this on as a serious issue. And maybe I pivot back to you, Dr. Bean Mayberry.
So, as I think Dr. Washington mentioned this in her talk, the End Harassment campaign started in 2017, focusing on staff training, VA staff training, in addition to increasing awareness at the local VAMCs or sites of care. And as part of that, there have also been these brief feedback with data feedback sessions with data collection from the clinical site. Anonymous one-page form, first one done in 2017. At that time, there were 1,300 women who responded anonymously and stated that they felt, 85% of them felt welcome at the VA, which was really good to hear. But there was also a concern about having stranger harassment experiences when they walk into the VA environment. And this is not MST. This is people in the setting who might be displaying disrespectful behaviors and behaviors that make you feel fearful, afraid, or angry, and not welcome. And so those data just got recollected again at the end of 2019 and are being looked at now to see if those stranger harassment experiences have changed at all.
I think that's such an important point, because the reality is we are social individuals who come from a cultural journey that is very heavily influenced by who is our family. And I wonder if we could even comment a little bit about the importance of honoring veterans' families, whomever the veteran feels is their family, so that that person can accompany, or persons can accompany them when they come for care, which I'm sure is another stressor in this COVID-19 era, where we're trying to limit the number of people who are coming in for care. But would anybody want to comment a little bit about working with families in that regard? And recognize.
Actually,
Dr. Washington.
Yeah, actually, I was about to make the point that you just did, really reiterating the importance of defining family from the perspective of the veteran, addressing issues such as military sexual trauma. Family for the veteran might be the support system they might need to bring with them to feel safe. From a cultural perspective, certainly there are some cultures and groups where having large family members, or having family members accompany them might be part of the norm, might be part of the support system. Certainly, there are different family structures in different places where the family, either respected elder people in the family or others, are the ones that translate or that sort of provide that litmus test of trust for determining whether recommendation to a healthcare provider should be followed or not. It is really challenging with the physical distancing of the current pandemic to allow that. But I think we should look into ways we could take advantage of technology. For example, having Zoom calls that go beyond one-on-one face-to-face visits between provider and patient to expand to group visits that incorporate their family members. So we can look at some of the challenges of the current era as opportunities to do things better and differently going forward.
Thank you so much, because we know, and I know Lauren knows a lot, the importance, and anybody who works with mental health, of peer support, and the extensive peer support network that is now being implemented to try to not only work with families, but work with others outside of the traditional medical arena of workforce to provide support to our veterans. One more question, as we have like 1 minute left, would be to talk a little bit about anybody who's had experiences with our American Indian and Indigenous populations who have been overrepresented in service to our country in the military, and therefore in our veterans, and any particular programs that address their needs. And I'm sure that this is more geographic related, where we have a larger population of veterans who are in Native and Indigenous communities. We realize, I think, that there are going to be situations where we are going to be combining folks who, one thing is known is that our Native American members who have had federal service sometimes get their care from both Bureau of Indian Affairs and tribal healthcare systems and Indian Health Service, as well as through VA. And so we know that that is a population that could be getting their care from more than one federal health system. And I think that that's something that we have to address as we think about providing the best access for all special populations from a variety of racial and ethnic and cultural groups.
That is very true. There are several research studies that have looked at dual use of VA and Indian Health Services, and have taken it beyond just characterizing the dual use to really trying to understand it, trying to sort of explore best ways to blend the services. I think going back to the current pandemic, certainly one of the challenges, that is a group that's been devastated by the pandemic, also often related to social determinants of health, much of which may go beyond what is immediately available through health services. I think proactively reaching out to patients, to veterans that may be at high risk for adverse outcomes, not only from the pandemic, but from other catastrophic situations in the future as well, is one way to understand, assess the needs, and see sort of how services may be coordinated better. And then to, similar to the programs developed for homeless veterans, to really try to understand by incorporating more of the voices of people from American Indian, Alaska Native groups, think about how some of the VA social services could be better directed toward addressing those needs.
Thank you so much. I there are so many questions that we've had answered, and we are out of time. So I trust that we will be able to summarize these as the final report is put together. And I want to thank our excellent panelists who are really committed to delivering access and patient-centered access to our special populations. Thank you very much.
Okay, thank you, Dr. Southpaw. This has been really a rich discussion, and what I'm left feeling is that it would be good if we could take a couple of days actually to flesh out and to respond to this, so many questions that we didn't get to, but actually to flesh out these issues and how do we translate the data into actionable things that we can operationalize in the short term. Because I think there are just so many opportunities to make the system work better.